Hello and welcome to sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name is Glenn Minturn and I'm excited to join you as we meet some of our clinicians and deep dive into specialty areas from across Mater's facilities in Townsville and Mackay. Today I'm coming to you from Kutharinga, the land on which this podcast is recorded, and I'm joined by Dr. Craig Costello, a neurologist at Mater Private Hospital, Townsville. Dr. Costello is a clinical neurologist with subspecialty training in neurophysiology completed at the Royal Melbourne and Austin hospitals, and provides clinical neurology consultations to North Queensland in both Townsville and Cairns. Dr. Costello recently trained in Deep Brain Stimulation on a visiting basis under Professors McDonald and Wilcox at Calvary Adelaide Hospital, and since then has commenced a Deep Brain Stimulation service right here in Townsville, the only regional service in Australia. Today he's joining us to talk about the clinical indications and benefits of DBS now available locally.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Dr. Costello, welcome to sMater.
Thank you.
So Craig, let's talk about an interest you have, and that is deep brain stimulation. What sparked that special interest in that specific area?
It's really easy. Three things: need, opportunity, and passion. So I've been here almost 12 years in Townsville. It was very obvious very quickly the amount or the number of patients that have Parkinson's disease. And if you look at the figures across the North Queensland region, it would be estimated that there's 3,000 to 4,000 people with Parkinson's disease. Clearly not all of them have been diagnosed or regularly see neurologists. So that's one thing. So there's certainly a massive need for Parkinson's disease and tremor treatments. Opportunity came by 3 or 4 years ago to go and learn deep brain stimulation under the Calvary Adelaide team, who are visiting here to help us provide this service locally. And really, finally, is passion. I'm a regionalist.
Yeah.
I'm over the concept. I don't even think I ever had the concept that people should need to travel for care. And where you've got local expertise and you've got the ability to foster that expertise and provide that care locally, I am going to back that and support that, whether it's in neurology or outside neurology. Where we can develop it here, we should develop it here, and we should provide care locally here.
Deep Brain Stimulation as a therapy for Parkinson's patients celebrates its 30th anniversary in 2023, with the Journal for Stereotactic and Functional Neurosurgery recognising DBS as a universal method for therapy and research across neurology and psychiatry, with patients nowadays in all functional stereotactic neurosurgeries benefiting from higher levels of precision and safety than 3 decades ago.
Give us a bit of an understanding of what is DBS.
So deep brain stimulation, quite simply, the easiest way to explain it, it's a bit like a pacemaker for the brain. Gotcha. So there's 2 wires, one on each side, that are placed in deep targets in the brain, and there's electrical activity delivered constantly that overcomes the abnormal electrical signals that are producing the symptoms.
And how does DBS compare to medication when it comes to something like Parkinson's? Is there a big comparison or a big difference?
There is. So many people with Parkinson's disease, the drug's very good, and they're very good early on, typically. The problem is the longer people have Parkinson's disease, because it is a progressive disease, they require more drug. And then the drugs can have side effects as they get into higher doses, so they can get excess movements. The drugs can also fluctuate. So they get what we call on and off symptoms regardless of being on medication. And some of that's reliant on because their gut function for absorption of medication doesn't work as reliably as it should as we go further down the line of their disease. So the biggest difference between drug and deep brain stimulation is that deep brain stimulation is on all the time. There is no fluctuation. It is there going 24 hours a day, 7 days a week, whether you're swimming or, riding a bike or doing an interview, the deep brain stimulation is going. And then the other big thing between deep brain stimulation and medication is that Parkinson's disease is an asymmetrical disease. And I keep on referring to Parkinson's disease because it's the most common indication for deep brain stimulation. It's an asymmetrical disease, so it's always presenting at the beginning on one side or one side worse than the other, and it remains worse on one side than the other throughout the course. Deep brain stimulation, you have two leads. You have one pulse generator or battery, but the two leads are independently programmed. So it's the only therapy where you can treat different sides of the body differently. Whereas drug, you give drug, can't tell the drug to go to the right, to the left. And so they're the big differences. Probably the other big difference and one of the main indications for use of deep brain stimulation in patients with Parkinson's disease is control of tremor. The medications are known to be good, but not get control of tremor anywhere near as well or as confidently as you do with deep brain stimulation.
Is DBS for all patients, or still have to make assessments as to whether they can work on an individual? Or can you basically say we can attempt this on all of the patients with DBS?
I don't think there's any procedure that's for all patients. And that's certainly the case with deep brain stimulation. So the process of deep brain stimulation for any patient requires an assessment by a multidisciplinary team. And it's because there's no set point where a patient might be recommended or be considered suitable or potentially suitable for deep brain stimulation. So we have to go through a process to be confident, A, that they've got Parkinson's disease as the main indication. The other indications are essential tremor or dystonia, but they're not as commonly done, although the therapy is very good for them. With Parkinson's disease, we would typically be looking at patients that have been diagnosed for 4 or more years to be confident that they're not, if you'd like to say, taking a little bit of a left-hand turn and heading in a slightly different direction, because sometimes that does happen. We want to be confident that they're responding to the actual dopamine that we give them as a drug, and we do some clinical testing for that. We want to be confident that there's no psychiatric difficulties or contraindications, so they have an assessment with a neuropsychiatrist, and we want to be confident that they're not developing cognitive decline or a Parkinson's disease-associated dementia, and so they have a neurocognitive evaluation with a neuropsychologist. Some patients, because of the longevity of their disease, will also have allied health assessment to assess whether and be confident that they're actually going to get the benefit of it. So it's a pretty big procedure, and you need a patient that's desirous of it. If a patient's ambivalent or not desirous of it, then that would be something that would give us concerns. And we want to be confident if we're going to say to a patient, you're going to go through this, you're going to have what is brain surgery, you are going to have a period of recovery, that they're going to get good functional outcome from it and that it's going to be worth it. So there is a process, but it's an important process, and it's a process that then allows us to confidently select patients and produce outcomes that are really beneficial for patients.
Despite a diagnosis of Parkinson's in a person under the age of 50 being considered early onset, the Australian Aged Care Guide revealed this still accounts for 1 in 5 cases, meaning there are a significant number of Parkinson's patients who are working age.
So, Craig, we're seeing our population in Australia age. There's no doubt about that. Are you seeing a correlation between the ageing of the community and an increase in that neurodegenerative diagnosis in the area that you work in?
I couldn't give you exact figures, but yes. Most of the diseases that we deal with in neurology are more common with age. And that's conditions that are not even neurodegenerative, such as stroke, for example. But certainly the neurodegenerative conditions, Parkinson's, the wide range of dementias are more common with aging. And with an aging population and more people living to older ages, we do see higher rates of diagnosis.
Deep brain stimulation is performed on patients while they're awake. Can you give us an indication of why it's important that the patient is awake during this procedure?
Yeah, that's really simple. If you're having deep brain stimulation, you want the lead in the right spot. And being awake allows us to do clinical testing whilst they're in theatre to be confident that the lead's in the right spot. So this is a procedure done by a neurosurgeon. And what's really interesting is it's really a team environment. So I'm not putting the leads in, the neurosurgeon is putting the leads in. I'm on the clean side of the barrier, talking to the patient, making some jokes, getting them to do a few different things, and assessing their response to test stimulation. And that's because the effects can be are immediate. So we can see a resolution of their tremor by testing stimulation in theatre. We can see significant improvements in their ability to do repetitive quick movements or the stiffness that we examine them for. That can all be seen virtually instantaneously. And so we do clinical assessment as well as electrical recordings, which we need the patient awake for, and that allows us to be really confident that we've got the lead in the right spot.
So with the DBS, the benefits are almost instantaneous from that moment while you're doing the procedure from there on?
Yes. Yeah.
That's amazing.
Yeah. And it's one of it's probably the coolest part of my job to see the change in people. Now, honestly, to remember that patients, whilst they're awake, they've got some sedation and the anaesthetist there helping them through it as well. And they often don't remember a lot about the actual surgery. But to see them, 24 hours later in ICU and sort of ask, well, where's my tremor? And to see that really significant improvement so quickly is, it's joyful, it's fun, it's what it's all about.
Mayo Clinic publications classify DBS as a low-risk procedure due to 30 years of the therapy worldwide developing methods of best practice and the extensive training of specialists prior to completing the procedure. However, they do recommend ensuring honest conversations are had with patients prior to procedure. It is not a cure and it isn't for everyone, with success relying on several factors to be determined in consultation with the neurologist.
So, Craig, looking at those patients you've treated to date so far, can you give us a bit of an idea about that patient journey? What does it look like from their first consultation with you through to rehabilitation and those post-procedure checkups?
I can give you a pretty good idea. The simple thing to say is they better like me because they're going to see a lot of me.
Lucky you're a likeable bloke.
Lucky. So the whole journey, if somebody turns up and I'm starting to talk to them tomorrow, you're probably looking at, a 6 to 12 month odd journey. It's not like we're going to talk to somebody tomorrow and operate on them next week. We need a chance for them to get to know about the procedure and us to get to know about them and their disease, and do all of those assessments and make sure they're suitable and make sure they're desirous for the procedure, and that they understand what they're committing to doing, really. So that takes some time. In the really close period, once we've gone through that multidisciplinary process and had a consensus opinion that they're suitable and therefore offering deep brain stimulation to a patient, probably the last month is the where I guess things start to heat up. So there's consultations with myself around that education process. There's a fairly detailed MRI scan that they've got to have, and there's a bit of preoperative education from the allied health team. They come in the day before surgery. Some people would consider it mean, but we take them off all of their medications because we want them to be maximally symptomatic so that we can assess the response. The first part of the surgery, is they have a frame attached to their head, and that's probably the most disconcerting part because it looks fairly uncomfortable from the outside. But that actually is really important because it allows us to find the targets and put them in the right process. The surgery itself probably takes 3 to 4 hours. They wake up in ICU, and throughout the coming weeks, there's lots of changes. Their stimulation is being changed and programming being done, and their medications have been changed. And if they need to, they will stay in for some rehab. And after discharge, I typically will tell patients they're going to see me weekly for the first month, and then we start to space it out. And probably after about 6 or so months beyond surgery, we should have them in a position where we've got the ideal programs for them, we've got their medication ideally significantly reduced, and that they're starting to really just have those big functional benefits and get their life back and get some control of their life back.
Now that you've done a number of these procedures, what are the sort of outcomes that the patients are reporting back to you? Because obviously there's some big changes for a lot of these people's lives. So what are the things they're giving back to you as to what you would see are the outcomes of DBS? It's
control. I think the biggest thing is when they have the confidence that their symptoms are going to be controlled, they know that they can go and do things and plan and do things and undertake activities, so to speak, like a person that is without disease. So it's not to say that they don't have any symptoms whatsoever, because if we were talking about no symptoms, then we're talking about cure. And unfortunately, we don't have the ability to talk about cure in these conditions. But from people who were effectively housebound because they couldn't sit still, to coming back and saying to me, look, I don't really think I need to see you. Can we, just space these appointments out because I'm going on holiday? That's a really positive outcome, but it's a positive outcome because it comes from them feeling like they're in control of their disease rather than the disease in control of them.
So just before we wrap up with Dr. Craig Costello, it's time for us to introduce our little segment we like to call The Checkup. All right, Dr. Craig Costello, before we wrap up, we're going to hit you with our 5 quick-fire questions to find out a little bit more about you, the person, rather than you, the medical professional. Are you ready? Let's see how we go. First question up. What's your favourite meal?
Thai salmon salad.
Do you make it yourself?
No.
How accurate is Grey's Anatomy?
I've never watched Grey's Anatomy.
Do you watch any medical shows?
I used to watch ER.
Yeah.
And I used to love that little Benton move that down the corridor in the intro. Sadly, I fell over trying to do that once, so I gave up.
What is your theatre playlist. Do you have a theatre playlist? Are you allowed to have a theatre playlist?
That's the perspective of the neurosurgeon, and I dare not interfere with the neurosurgeon's playlist.
Does he have one? Do they have one?
Yeah, from time to time.
From time to time? How many coffees would you consume a day, noticing that you've had a couple today while you're out riding your bike?
On a cycling day, many, 4, 5. On a non-cycling day, 1 or 2.
All right. And
Is there a day without? No.
No, always got it. And a final question. Do you have a hidden talent?
Definitely not singing. I must have a hidden talent somewhere. Basketball.
You're a big fan of the basketball?
And I've managed to win the corporate 3-on-3 comp 2 years in a row. So hopefully we can go for the three-peat.
There you go. Looking for the three-peat. Dr. Craig Costello, thank you so much for joining us on sMater.
Thank you.
So for our listeners at home, in the car, or having a well-deserved break between patients, thank you for tuning in. See you next time on sMater.